Good afternoon, everyone, and thank you for joining us. There are almost 500 people registered for this webinar, so we're going to give everyone a few minutes to log on and also allow us to set up our live stream to Facebook for those who were not able to register but still want to participate. Okay, good afternoon again. We are now streaming to Facebook, and there are several people who are already in the webinar, so I'm going to go ahead and get started. My name is Colleen Cipriani, and I am the Assistant Dean for Inclusive Excellence at the Gilling School of Global Public Health and Clinical Associate Professor in our Public Health Leadership Program. I want to first begin by acknowledging that the University of North Carolina at Chapel Hill is built on land previously inhabited by the Occaneechi Band of the Saponi Nation. North Carolina is home to 8 indigenous nations and has the largest indigenous population east of the Mississippi River. We acknowledge and give thanks to the first peoples of this land and their descendants. We look forward to building upon the honored memories and goodwill of all who walked and labored here before us. On behalf of everyone at the Gilling School of Global Public Health, located on the beautiful but now pretty quiet Chapel Hill campus in North Carolina, I want to welcome you all to this inaugural webinar in our new Inclusive Excellence series entitled Emergency Preparedness, Ethics, and Equity. The COVID-19 pandemic has been sweeping across the United States and the globe for the past few weeks, exposing and amplifying the chinks and chasms in our emergency preparedness armor. There have been shortages of masks and PPE for those frontline workers who need them the most, healthcare worker shortages, and respirator shortages. At multiple levels, there has been a lack of guidance, disagreement over guidance, and changing guidance for a confused, frightened, and angry public. Unfortunately, but unsurprisingly, COVID-19 has also exposed and amplified deep and persistent societal and health inequities in the United States. The optimists among us are hopeful that the COVID-19 pandemic and response represent much needed catalytic events that will finally begin to transform our collective acknowledgement, approach, and action regarding US health inequities. Today, we awoke to the news from the White House of an impending executive order to temporarily suspend immigration into the United States, and to the news that the COVID-19 US death toll surpassed 42,000 people, essentially doubling in the past week. Also this past week, we were inundated with reports, articles, and TV specials highlighting preliminary data that indicate people of color, particularly African Americans, are disproportionately represented in reported infections and deaths in places like New York, New Orleans, Chicago, Detroit, and St. Louis. While US reported cases continue to grow in some parts of the country, in other parts, states are easing some restrictions despite the fact that public health experts and scientists insist we have neither the increased testing nor the decline in cases needed to safely ease restrictions. In Indiana, elective hospital surgeries are resuming immediately, and in Georgia, gyms, hair salons, and barbershops will reopen this week, although Albany, Georgia is facing the 4th worst outbreak of coronavirus per capita in the US, and nearby the Atlanta mayor implored her residents to continue to adhere to stay-at-home orders while announcing a public health-focused strategy to safely reopen that city. In this first webinar entitled, What Have We Learned from the Past? What Should COVID-19 Be Teaching Us? We will explore how this pandemic is unique in many ways when compared to past events such as Hurricane Katrina. We will also discuss just a few of the questions of ethics and equity that should be of concern to all of us, especially as we consider potential second waves and future pandemics. At this time, I'm pleased to introduce our distinguished panelists whose bios are available on our website, which you can see at the bottoms of your screens right now. Ms. Nicole Dozier is the Director of the Health Advocacy Project at the North Carolina Justice Center. Dr. Gloria Rashad Davis is Professor and Executive Director for the University of Arkansas Medical Sciences Division of Diversity, Equity, and Inclusion, Division Director for Reproductive Endocrinology and Infertility, and Medical Director for the Physician's Assistance Program there. And Dr. Jim Thomas is an Associate Professor in our Department of Epidemiology, right here at the Gillings School of Global Public Health, and Director of the Measure Evaluation Project for the Carolina Population Center. Panelists will be speaking for 10 minutes each, and at the conclusion of all three presentations, I will ask our panelists to respond to some of the questions that you all have submitted through the Q&A portal. With over 500 participants and only about 30 minutes, I doubt we can get to all your questions, but we will do the best we can and remind you that there will be other opportunities to respond to some of your questions at future webinars. So I would, at this point, like to turn it over to Ms. Nicole Dozier.
Hi, everyone. And thank you for that great introduction. I'm just really happy to be here with everyone. So the mission of the NC Justice Center is to essentially work ourselves out of the jobs that we've been doing to improve the lives of people in our state. And what we focus on is really to eliminate poverty. And so the way we do that is by attacking it at its roots and using a variety of strategies, working on a variety of issues. And healthcare is just one of those issues that impacts people's ability to take care of themselves and their families. So I want to start out with 2 points I think that are important to mention today. Is that first, W.E.B. Du Bois had a famous quote, and he talked about how the problem that we have that's followed us into now the 21st century, he said, is the color line. And it's likely most evident in our health outcomes. Second, but say with COVID-19 in America, we have seen more of a national conversation that the rest of the developed world has already had, and decided that they would ensure the people in their communities and that there would be universal coverage. And somehow the best, what I feel like is the best country in America, we are still stuck in the 20th century trying to figure out why our healthcare costs are rising, why there's lack of access for everybody, why inequities persist. And so I would say that universal coverage is critical in this moment. There are many paths to get to universal coverage, leaving no one out, but it's an illusion to think that we can leapfrog this essential step and still make progress toward a high-performing, equitable healthcare system that works for all. Related to COVID-19, we know that workers are on the front lines. They are not just healthcare workers, but that are considered essential. But now we're finding people that often we had to fight for their ability to get essential pay to be able to take care of their families. But people who are making sure that our kids are able to eat, they are people who are making sure we're able to buy what we need to be safe. And I would say that they have been essential workers all along. But now COVID is sort of revealing for us that the folks who are able to keep us, keep our homes clean and keep us safe when we're going to purchase things, these folks are on the front lines, but many of them are not able to afford health insurance or able to access healthcare on their own. We want what we need for not just healthcare workers, but for people on the front lines to be able to feel that they are protected from us and the public. There should be things like the screening between folks. They should be able to be socially distanced from us. And so those are the folks that we really got to make sure that they are able to do their jobs and not be feeling fear of being in the space with us as well. Providing health insurance to people who are losing their employer-sponsored coverage is key. There are estimated 240,000 people right now in North Carolina who will have losing their coverage with their jobs, which to me sort of elevates the point that being in a job where insurance is tied to it just doesn't work. And this is why we have to figure out how we have a system that works for everyone despite your work status. And another thing that the key thing that I've spoken about for many years now is expanding Medicaid. Well over 500,000 people in North Carolina are still stuck in the coverage gap, waiting for rescue from state lawmakers to provide them with coverage. And I think we're going to see, unfortunately, as people are losing their employer-sponsored care, as people who previously were paying for insurance, out of pocket in different ways, are going to be in the coverage gap because they're not going to be in the deserving, in air quotes, quality, deserving categories rather, of being a pregnant woman, a child who's low income, or extremely low income parent. This is why we have to remove barriers and cut down the categories, and let's just get to everyone deserving to have access to health care. The reason that we haven't been able to do that in America is because, in my opinion, and I think the Justice Center backed me on this, is that policymakers have not decided that all their constituency deserves access to quality, affordable, equitable, comprehensive care. Once policymakers decide that's the value, then we can move forward. America was founded on a system of inequality, and we haven't figured out how to break that system down in a way that we can build it up to honor everyone and honor everyone's voices and experiences. And so one of the things that we want to make sure that we do in our work is not just to be considered a policy shop, but also a place where we connect policy to the people that we're working on behalf of every day. And the way you do that is by connecting with people in a real way who are most directly impacted. We have traveled the state previous to this epidemic, and we have talked to young adults who have lost their parents who are very young as well because they lacked access to health care. We have met with mothers who have lost their children to substance use disorder because they could not get behavioral health and mental health care that they so deserved. The stories that we hear break your heart. We have had direct contact with people who he and his wife both became disabled because they couldn't get care, but he actually used duct tape on one of his limbs because of fear for going into the emergency room and having medical debt on top of everything else. So when we treat people like they don't deserve something that I think all of us deserve, we have what we end up with is inequities. So I do have a few slides that will show you a little bit of the numbers related to COVID. So if you look at Michigan, you see that, and I hope you can see the numbers here, but how people of African American or African descent are 14% in Michigan. You see that 33% though of the cases, are African American, but then you see how many people have passed away in Michigan. It's way out of whack for the percentages. Next slide. In Illinois, we are African Americans are 15% of the population in Illinois, 25% who are have COVID, and then 40% of the deaths. Next slide. For Chicago, we're looking at 30% of the population, 46% have COVID-19, and 57% have passed away. Next slide. The South in COVID-19. So what I want you to consider is we think about, we hear people talking about rural South and urban North, and talk about it like it's just one set of people, and people in rural areas in the South where my parents originate are very different, and it's just like one type of rural individual or people. But we do know that with more densely populated areas that are more urban in nature, there will likely be more rapid transmission because of social distancing is harder to achieve. And so if you look at also in parts of our state, especially where people are not as close to hospitals, and then where we've had 7 hospitals close or either pull out their maternity coverage, maternity services, we see, disparate health and life quality right here in our state. And you see people just sort of say, well, I'm just riding this out at home. And we hear that when people talk about natural disasters, I'm gonna ride it out at home. Well, this to me is a natural disaster. We just haven't put the right investment in people to help them survive it. Next slide.
1 minute, Nicole.
Okay, thank you. Okay, Louisiana, you just see how stark. We didn't get the number of people that are, I'm sorry for that doorbell there, but 33% of the people are African American in Louisiana. But let's just look at the deaths at 56%. Next slide. We can go, next slide, go to North Carolina, I think. You can go to North Carolina. North Carolina, we were 22% of the population here. 39% of us have been diagnosed with COVID-19. And about a week ago, we were at 22%. Now, in 1 week, we are at 38% of the numbers of deaths. So I think that's my time. Thank you so much.
Thanks, Nicole. We're going to quickly transition to Dr. Gloria Rashad Davis.
Thanks, Colleen. It's a pleasure to be with you. Thanks for the invitation. I am faculty at University of Arkansas, and we are the only academic health center in the state of Arkansas. Arkansas is a very rural state, so we spend a lot of time delivering care. I have patients who travel 3-4 hours to see me. So it's not unusual for us to use telehealth, which most of us are getting very comfortable with now, but that's been part of our normal. Next slide, please. So I'm sharing this slide with you because it's an image that was shared through our AAMC affinity group on diversity and inclusion. And I love what it says. It says nothing should go back to normal. Normal wasn't working for our communities. If we go back to the way things were, we will have lost the lessons. Maybe rise up and do better. So don't waste this crisis. There are lessons that we have learned, and it should help us to forge our path forward. Next. So I lived through Katrina. I was actually living in New Orleans, and I trained prior to that in the Army Medical Corps. In our training for the military, we trained for wartime. We worked in civil peacetime, but really we continued to train for that mission when we were deployed for wartime. Unlike the military, our civilian health community does not train everyone to deal with these crises. We have emergency prepared teams that train for this, but not the general healthcare system. So I wanted to just kind of reflect on some of my experience with Katrina and contrast that to COVID-19. In both scenarios, we do have warning systems, right? With Katrina, the hurricane response center tells us before time, they're tracking, they let us know. And most of us who grew up in a hurricane-prone area, we knew exactly what needed to be done. And that was get your critical things together. I had a bin, I'd pick it up and move out of harm's way. With COVID-19, there's no place to run. There is no place that's really safe. This is a pandemic that's affecting us globally, certainly nationally, and it's affecting every community. So there's no safe zone. In both cases, there's an aftershock that we can expect to see with COVID-19. In Katrina, we saw higher mortality from MI, stroke, asthma, because it was much more difficult getting medications and healthcare in the wake of Katrina. With COVID-19, we're not delivering routine care. So there's going to be aftershock from that. Next. This warning systems that are in place, again, the federal government really should be providing our support through crisis. It is FEMA, or the Federal Emergency Medical System, that is the backbone of that. But unlike when you're talking about a state response, this is now a national response. So we expect that the federal system should be there to help us. The national stockpile, which was created in Y2K in 1999, we no longer need it because we were expecting the supply chains to be disrupted. It was not. But they did keep the national stockpile because there was anticipation of bioterrorism and perhaps needing it then. This is now when we need it. Next. So we talk a lot about poor health outcomes in our vulnerable community and our community of color, but you really have to back up and look at the structural issues that has contributed and continues to contribute to this. Our policies, our economic system, social hierarchy, racism, leads to poverty and inequality, and hence poor health outcomes. Next. So this is just kind of to look back at the timeline of COVID-19. This was a publication from January 24 in The Lancet. The first case was December 30. Fast forward, it started in Hubei, China. And if you fast forward through, what this takes you is towards the end of January, it was still pretty much in China and the surrounding countries like Korea and Japan. So we went through December, January, February, March before President Trump declared a national emergency. Next. If you can start that video, this is basically a time-elapsed video showing you, we started out in China, clearly leading infection rate. As we went through here now, into February, we're starting to see US cases. And then you'll see very quickly how the infection rate spread across the US, such that now the US leads in the number of infections. And that was a failure of our federal response system. We really should have done a better job of, we couldn't contain it because really you can't put up barriers against a virus in a global economy. But we should certainly have looked at mitigating earlier with some of the things that we're doing. Next.
Hello, Gloria. Okay, sorry everyone. It looks like we may have lost Gloria. And so we are going to transition to Jim. And when Gloria rejoins us, she will finish her conversation. Jim?
Hello, everyone. I got into ethics because I was studying the social determinants of health in North Carolina. And as a social epidemiologist, I've run into a lot of very basic issues that relate to race. And actually, before I continue, let me just note that I can see Gloria. And do you want to go back to her, or do you want me to keep going?
Oh, well, let's go back to Gloria. Thank you, Jim.
Okay, sorry about that. I am on my phone and had interruption. Okay.
No problem.
So this is really flattening the curve, and flattening the curve really means that we're trying to reduce the infection rate such that our healthcare system is not over its capacity, or doesn't exceed its capacity. Next, so the measures we put in place, hand washing, social distancing, all of us are familiar with, and that is to flatten that curve. We did add very late in the process, adding wearing masks, which the CDC added in really earlier this month, April 3rd. So the risk of resurgence is really now what we're focusing on now. You can see we have the curve flattened. when we start going back to trying to return to normal, we expect that there will be a resurgence of infection. Next. This slide really captures the essence of the footprint of this pandemic. If you look, the first wave was the immediate morbidity and mortality associated with COVID-19. Then we had the tail post-ICU recovery. We've got the second wave, the impact of resource restrictions. So you're having urgent conditions treated, but that's it. Nothing that's chronic or considered elective. The third wave is that impact that I spoke about on the chronic conditions that have been unattended at this point. And then the fourth wave, which is true in most crises, but more so in this crisis than any other, and that is the expectation of a pandemic of mental illnesses. Next. So all of us are stressed, and I wanted to just show you the impact of stress on our bodies. There is none of our system that's not affected by stress. And the diagram on the left really shows you the highest level of stress is losing a loved one. In this pandemic, we have experienced every possible stress, a disruption to our normal life. And when you start adding all of those points up, that equates a significant amount of stress, and it will have an impact on us because this is not acute, like a day or two. This has been now chronic. Next. So the pandemic that I spoke of, where we're talking about the fallout from the social distancing that we have and the grieving process that we're going through for what was our normal way of life. This is a traumatic event, and really we're talking about crisis counseling, not just traditional counseling. So some of the things that we can do is try and maintain some normalcy in our life. Keep your routine, eat healthy, exercise. Recommendation was to actually keep a diary, a gratitude diary, so that as we're losing so many things, keep track of the things that you are grateful for on a daily basis. Next. The racial data in this pandemic has been interesting and key to how we're going to decide how to respond to this, particularly in communities of color and vulnerable communities. So race reporting in terms of testing is only now done in 2 states. Next, keep going. And so you fast forward, there are about 36 states that's reporting race data in confirmed, and only 24 that's reporting in death. So we need the data in order for us to be able to really respond and affect what needs to happen post-crisis. Next.
1 minute, Gloria.
Okay, our health inequities, we're all familiar with. The social determinants of health is far and wide, and the healthcare system only affects about 10% of healthcare outcomes. So many of our community have pre-existing conditions that we know increases their susceptibility to the infection and decreases their response to it. Next. States that have expanded healthcare, we heard Nicole speak to, there's 14 states that did not, and North Carolina is one of those. Next. This is the beginning of a roadmap which has been organized and published through Harvard's Center for Ethics. But it's a joint effort from a number of different centers looking at how do we start to reintroduce what was our normal way of life and what's the impact going to be. How do we slowly get there? Because they're talking about not a big bang, but regional approach to reintroducing normal so that we have better control on what we expect to be a resurgence. Next. So our strategies going forth. You know, we think about how do we take this lesson and really help to design the pathway forward. We want to highlight the health issues that have resulted in an increased risk of dying And we also want to look at our infrastructure, like our emergency response system, that certainly needs a lot of work going forth. The national stockpile, which was inadequate, and to really look at the racial structure and the impact that it has had on our health as a whole. So there's a lot of work to be done in the aftermath of COVID. COVID pandemic will come to an end eventually, but what is needed in the aftermath is that we renew our focus to ensure health is not a byproduct of privilege. Lastly, last slide. Oh, there was one more. Anyway,
Oh,
it's okay.
thank you, Gloria, and I'm glad we were able to get you back in so quickly. Jim? Unmute, Jim.
I am unmuted.
Thank you.
Are you able to hear me?
Yes, now we can hear you. Sorry.
All right. I mentioned briefly a moment ago that I got into ethics because of working around social determinants in health in North Carolina, and was looking for a language to talk about some of the racial issues that I was uncovering in my work. So when I'm going to be talking about some social factors in the COVID pandemic, and I'm going to first look back, and then we're going to go into the present and a little bit into the future. Next slide. So looking back and where we could have learned from, these are pictures that relate to mining in South Africa in the 1800s. There was a tuberculosis epidemic that was transmitted amongst the workers there. They came from throughout Southern Africa to work in the mines, and then they were put in housing that was substandard and very crowded and was ideal for transmission of tuberculosis once it became present in their communities. Once they were found to be infected, the companies would send them back home to their cities and villages, which further disseminated the epidemic. The companies were eventually held accountable for the treatment of their workers, and there were lessons learned about the importance of companies taking care of their workers that I want to address right now as we look at the COVID experience here in the US. Next slide. So I'm going to talk about some of our workers that live in conditions that are a bit similar. These are migrant farm workers in North Carolina. They live in a dormitory kind of situation. It's nicer than the workers in South Africa faced, but nonetheless, it is crowded, and if any one of these men should get infected, the others are very much at risk of getting infected as well. Typically, when somebody gets infected with COVID, they are isolated and removed from other people to minimize the chances of transmission. And that's a hard thing to do for farm workers. The farm owners don't have spare places to put people. The state doesn't have them. They are working on that right now. They're making some progress. The question is whether it will occur in time to prevent an outbreak of cases and potentially deaths in our migrant farm workers, which will in turn affect the food supply of the state and other states. Next slide. Next slide, please. Another, go back one, please. Another place where we find low-income workers is in nursing homes. This is a picture of a nursing home in North Carolina where the last I looked, they had 57 cases in this nursing home. Many of you may have read about an instance in New Jersey where they had 70 deaths from COVID in a nursing home. I have spent a great deal of time in nursing homes of late with my mother and my mother-in-law, and I know well that many of the caregivers are African as well as African American. And the income is low enough that they often have to have two jobs, which can help transmit between nursing homes. But the elderly are not yet thought to be more susceptible to infection, but once they get infected, they are more susceptible to death. But once, because they're in a crowded situation here, once the infection enters into one of these homes, it can spread very quickly between the patients, as we're beginning to see now, and then also to the workers who are there. And here again, we see that the employers have responsibilities to those workers, but there isn't a lot of evidence that those responsibilities are being paid attention to. Next. That's right, there we are. So this slide here is, it's showing cell phone movement. And so going from left to right, we're looking at time, and where the ups and downs of these curves drop below the line, that is when social isolation was put in place. And the brown lines are from our cell phones from the wealthiest neighborhoods. The blue lines are from cell phones in the poorest neighborhoods. No, I got that backwards. The blue lines are the wealthiest, brown are the least wealthy. And you can see that the blue lines are able to drop down lower and stay lower. The wealthier people are able to stay socially isolated better than the poor. And this slide has shown that social isolation is a luxury to some degree, because those who are unable to stay socially isolated, they are the ones, the low-income workers, who are working in the places that the wealthiest are using. Some examples follow. Next slide. Here we have Amazon Fulfillment Center, the warehouse where Amazon, things that you have bought probably in the last week have been fulfilled. And there was an Amazon warehouse in California where the workers filed a formal complaint that they were not being protected well enough to prevent transmission of COVID. They did not have time to go wash their hands. They had to walk too far to find a place to get hand sanitizer. And oftentimes when they got there, the sanitizer was empty. And so you can see here that it's not just the employers that need to be taking care of these workers. It's also you and me, and the amount of ordering that we do, a very complex ethical situation. But it does highlight that those who can stay home and order online are in a very different place than those that have to keep working, and those that go and fetch these things that we order. Next slide. And the people who work in the Amazon centers and other places that those of us who are social isolated need, those who go to those centers, they travel on public transportation, and they are at risk there as well. The people who are of lower income, again, are the ones who are most likely to be put at risk in these situations, the most likely to get infected because they are getting to work. Next slide. So those examples that I gave you connect to the TB example in South Africa, because they relate to employers and employees, and particularly low-income employees, and the risks that they are put into because they can't afford not to work, because they can't afford to remain in isolation. And we knew that this could be a problem because of what we had seen in South Africa, hundreds of years, more than 100 years ago. But we failed to think about that in our current situation. Now, we just heard Gloria say a minute ago that in preparation for emergencies, that there is a lot of planning and preparation and thinking through what could happen. But somehow with COVID, we did not think through the details, some of these details that I just shared with you, and the inequity of the impact has been significant. So if we failed to imagine what was coming based on previous examples, what should we be imagining now for the future that is unfolding before us as the COVID pandemic is unfolding? A few examples. Next slide. Well, you saw that slide with the brown and the blue lines going up and down, and those are from cell phones. And this map here shows the kind of tracking access or warrants that are had for obtaining cell phone data. There is a lot of talk now about using cell phones for contact tracing to find out who has been close to whom. Contact tracing requires, it can't be aggregated, it has to be by an individual person, so the personal identifiers there are available at some level. And there are instances where we can see that contact tracing through cell phones would be a very powerful tool. And I don't want to say that it should not be used under any circumstance. However, what else can those data be used for? What other kinds of contacts would be monitored once this tool is in the hands of authorities of some kind, whether it's public health, whether it's my immigration, whether it's TSA, who knows, what agency is going to be using it? What kinds of protections do we need that the availability of a tool to fight an epidemic won't be used in another way that is less ethical, less protective of civil rights? Next slide. In China, they went a step further. They put their cameras on drones and flew them over communities. This is an example of a drone flying over a community and seeing some young men out when they should have been in isolation. And I don't know what was said to them, what was done to them, but it's a pretty scary image of what an authority could be looking for and looking at. It's likely that those who would be out in a community would be lower income people because they are the ones who are out and going to work. Even here in my neighborhood where I'm staying sequestered, when there is work done in the neighborhood, landscaping or whatever, they are most likely low income people. So the attention from a drone, should it happen in our country, which I haven't heard of yet, would most likely focus on lower income people. They would be the ones that would be observed the most. Next slide. And then the third and the last thing I'm going to mention is the evolution of facial recognition, which is being used everywhere. If you have flown recently on some airlines, you have had a picture taken of you so that you can board the plane. And the next time you use that airline, you might not need your boarding pass because they'll just recognize your face and you just walk on. Facial recognition offers a lot of promise, but there are a lot of problems with it. It works best for white men. It does not work so well for women or for people of color. And when it identifies somebody who is suspect, then questioning has to follow. There has been some talk about the use of facial recognition. Should people be wandering from quarantine and need to be reminded to go back? Again, this is more of a futuristic thing. I don't see it yet happening in COVID, but once it is used and found to be helpful in one situation, those stories begin to make it more palatable, and we could end up yielding to some technologies that will take away some of our civil liberties if we are not careful. Next slide. So I want to end by mentioning that I've been developing a pandemic ethics dashboard that provides documents from earlier attempts to describe ethics in a pandemic. It was the influenza pandemic. And then there's also the Public Health Code of Ethics. Next slide. And it guides you through information in these documents that help you quickly understand what the ethical guidance is on particular questions in a pandemic. And it helps us to remember what has been and what people have thought about and what they have warned about. It helps us to hold on to what others have imagined before. And then as I'm finding, as I go through COVID and I look at this tool, I'm finding that there are things coming up in COVID that were not anticipated. and it helps me to stretch my imagination to think about what we're forgetting here and what we could forget in future pandemics, particularly those that affect low-income populations and exacerbate disparities that we have experienced. Next slide. And I am done. Thank you.
Thanks, Jim. Thanks to all of our panelists. You guys have certainly given us a lot to think about and absorb. I want to move right to the questions so we can take as many as possible in the 15 minutes or so that we have until the end of the webinar. The first question is directed to Nicole, but if Jim, Gloria also want to weigh in after Nicole answers, we'd be happy to hear your thoughts. So Nicole, what are the proposals in your mind to bridge the inequity gap? You're muted, Nicole. We need to unmute you.
Yeah, so I did answer the thank you, the answer to that. A couple of things came to mind is to ensuring that that there's leadership in a lot of areas that reflect diversity. So our governing boards, our policymakers, our task forces, all the places where decisions get made or recommendations get sent on to someone else, they need to reflect diversity. And it needs to be not just diversity that I'm in the room, you know, taking notes when I'm at the table and my voice is being included in whatever decision is going to occur out of that group. I think that we also need to think about that people who are delivering healthcare, you know, people who are making other decisions related to, for example, scarcity of resources, that it is not just one type of person making that decision, that we might have providers, sure, and people who are like data researchers, sure, but there also needs to be another voice in the room to ensure that not just numbers are looked at, but that we're looking at people as human beings. And the only way I think that we have robust conversations and have great policies is to have a diversity of voices at the table making those decisions.
The only thing that I would add is we know the importance of diversity and inclusion. And if you look at what's happening across our corporations, they have really underscored that if we have a workforce that is diverse and inclusive, it's better. And so all of those things with how we govern ourselves, we need diversity and inclusion in that arena as well.
Mm-hmm.
Yeah. Okay. All right, the next question is actually to the entire panel. So could one or all of you please comment on the move in some states to ease social distancing mandates? I'll
start out by saying it's concerning.
Mm-hmm.
I showed the diagram which really illustrates the resurgence of infection that we can expect. And I think the less careful we do this, the longer this pandemic will actually continue to exist. We'll see multiple waves if we are not very careful about how we reintroduce what should be, you know, our new normal of life.
I'll offer that I'm sympathetic with the desire to get back outside. I want to do that myself.
Mm-hmm.
But should it be done too soon, as it was in the 1918 epidemic in influenza, it leads pretty quickly to a second wave. And pulling people back in after they have been let out is going to be harder than keeping people in the first place. So that's just a caution I would offer.
Sure, and I answered that. I typed in an answer related to that. I think too, you know, I didn't talk about it here, but I do serve as a mayor pro tem of an APEX. So some of the orders coming out of Wake County, some of the language I helped put in there. And so I take it very seriously in that situation as well. So on both sides, I have people saying, you know, we need to support the small business owners, and we absolutely do. But we also need to support the people who we're asking to social distance, to stay at home. And I think what is hard is, and this is what has come down, I think, from the federal government down is that we were reacting to things very quickly. And I think we want to balance that. If we were asking people to stay home, then we have to make sure they have a home to stay in. Got to make sure that it's safe, that they're not experiencing interpersonal violence in that home, that if they do feel stressed and, you know, maybe where are they getting all their information from and all of that, then how are we actually supporting people so that they don't feel as anxious while they're at home? Do they know they're not going to lose their job? Are they going to lose their job or their business? So I think it would have been nice if if the federal dollars had reached the people who really need them now, so that people could actually be supported while they stay at home. But then as people ease the restrictions, I worry about people who are sort of at our mercy when we go into the stores and we're getting too close to them, or we're not, maybe we may not sure we feel well or don't. And if we are caring and don't know it, what are we doing to the people who may not have the sneeze guards, you know, the temporary guards that are up now and things like that. So I do worry about people who are on the front lines, who have become extremely important to us and should have always been, but some of them are uninsured, cashiers, you know, people who are, you know, serving our kids, getting our kids food, who are been getting many of their meals, 2 of the meals in the school. So I think that we have to balance that, and I don't have all the answers, but I don't think we need to do anything too quick until we figure out how to support people, proper PPE, and do we have enough testing and kits to ensure that people will feel comfortable, and will they lose their employment if we go into this and they don't feel ready to go back? Will they lose their jobs? So I think it's a hard question, and I think for me, I'm going to likely support whatever Governor Cooper tries to do, and what Wake County is trying to do, and just make it the best we can.
Yeah, thank you for those responses.
The one thing that I would add is the roadmap that I mentioned earlier to pandemic resilience. There were 3 key things that was important in considering return. That was widespread testing, which we do not have at this point. Only about 1% of our population has been tested. It really should be at about the level of 10% at minimum. And then to trace the contacts. The guesstimate is that you need 100,000 people to just trace contacts in order to mitigate against the spread. Right. And then the last thing is supported social isolation, which is what Nicole spoke to. And that is going to be isolated. We have to have a way to support those people so that they don't come back and reinfect us.
Absolutely. Yeah, great point. So we have a couple policy questions now. So one questioner asks, many of the chronic health conditions and associated inequities that increase COVID-19 risk originate in childhood. What role does child policy have moving forward? Anyone who would like? Thanks, Jim.
Yeah. I'll charge in. So I think that there's going to be some unexpected benefits, shall we say, that come from this pandemic. Certainly a lot of tragedy. I don't want to minimize that, but as we've heard in Gloria and Nicole's talks, that we shouldn't waste this crisis. I'm hoping that it will work for us, and I'm hoping that we will get universal health care. You know, that's the thing that I would most like to see come out of this. And it may take getting hit by a 2x4 in the head, like you know, across the whole country, with something like this pandemic, to bring us to allow us to see that we really need something like that. That we can't have a patchwork. A patchwork doesn't work in responding to this pandemic. And should we have that, boy, the number of things that it would solve, thinking just of the childhood illnesses that could be addressed much earlier and made less severe and less prevalent.
And I would just add that you really need to consider a holistic approach. You can't do child policies without looking at the entire support system for that child. And that's everything from education to employment and financial support. because no matter what we do from a policy perspective, those things, those underpinnings, if they're not addressed, will continue to plague the challenges.
Mhm.
Mm-hmm.
Thank you. We have time for one more question, probably, because it is asked to all three of you. So, do you all believe the need to minimize the impact, the inevitable second wave of cases outweighs the impact of a strongly weakened economy? So there are those who are arguing that we have to have one without the other. We can't have both. What are your thoughts on that?
I don't want to accept that it's an either or. I don't want to accept that it's just A or B. I think that we're just now beginning to exercise our creativity in how we can respond economically, how we can help some small businesses. Let's continue on that track and see what we can do. You know, speaking from an ethics point of view, we are responsible for what we know, and one of the things that we know is the deaths that would be incurred through another large wave. And that's the clearest outcome. The economic outcomes are a little less clear about how they would affect lives, life and death. I'm not saying that it wouldn't, but it's just less clear than the epidemic itself. And that clarity forces me to think that we must continue to try to stave off the deaths from the pandemic.
Mm-hmm.
And,
yeah. Oh, go ahead. Right.
I was going to say, I would agree. I think when we look at our experts and what's recommended, it's really more of a regional approach that you can start to return to some sectors of our society to normal and not necessarily have the global impact that really going out there and having a big bang approach to this would have. It's important also when you think about the communities that's paying the highest price for this is our vulnerable community. And in an economic upturn, they don't typically tend to benefit as much as our other communities. And so if we talk about this, we have to talk about it in conjunction with how do we help the inequities in those communities who are paying those prices.
Right.
Yeah, I agree with all of that. I do think that this is North Carolina, and I think we can walk and chew gum. I don't think it has to be either or. I don't think it has to be healthcare education. I mean, I think North Carolina, they argue about who's got the best barbecue. Is it Eastern or Western? That's the most that we should be arguing about. We should not be arguing about whether Tar Heels, go Heels, I thought I'd say that anyway, but whether Tar Heels really deserve equitable access to health care. I mean, it just means so much more for everyone else. If you don't believe that it's a moral test of government to take care of its people, to ensure they have enough, that they can make enough money to do things they can for themselves, because we all want to do that, then we have to figure out when people need help, what we do. When we're getting ready to have a hurricane, and by the way, there are people who are still recovering from that, and hurricane season, I think, begins in June. This is a natural disaster, and what are we going to do? And our response is going to end up telling a lot about us, and our children, our youth are watching us in this moment. And so I think expanding Medicaid and ensuring that, that people have a stopgap measure who have lost their jobs with their employment. And I think, connecting with our state lawmakers, the Speaker of the House has House Select COVID committee meetings, work groups meeting, leading up until the 28th when session begins. And we just need to go online and put in our public comment. This is how we feel about it. Thank you for having these work groups. And, let's work on this. Let's not drag our feet anymore. More and more people are going to be in the coverage gap, and it'll be more and more parents.
Thank you all. Thank you, Nicole, for reminding us of our individual responsibilities and abilities to affect change in our counties and our states for our country. Okay, so at this time, I would like to thank you all for participating in our webinar. Thank our panelists for their time and their expertise. I'd like to announce the next panel will be Friday, May 8th from 1:30 to 2:30. We're excited to announce that will be our second webinar in this Emergency Preparedness, Ethics, and Equity series. It's entitled Pandemic Protection for People Who Are Incarcerated. And our moderator will be Dr. Dana Rice, Assistant Professor in the Public Health Leadership Program here at the Gillings School of Global Public Health. And we'll also have 3 panelists, Dr. Lori Brinkley Rubenstein with UNC School of Medicine, Ms. Bernadette Brown of B. Brown Consulting, and Amber Piat, who leads the Health Instead of Punishment program at Human Impact Partners. Thank you all, be well, and stay safe.
Thank you all.
Thanks.